Welcome to the Practice of Medicine podcast from the Southern Medical Association. Since 1906, SMA has had a singular mission: to provide medical professionals with the resources they need to learn from each other, and in doing so, improve the overall quality of patient care. The Practice of Medicine podcast is just one of the ways we do that, as we discuss a wide range of topics, including the Physicians in Training Day in the Life podcast series. To learn more about SMA's many other services and educational initiatives, please visit us at sma.org.
Today, we are joined by Dr. Lauris Kaldjian, a professor in the Department of Internal Medicine at the University of Iowa, as he discusses his article on physician influence and shared decision-making that will be appearing in the Southern Medical Journal. Thank you so much for being here, Dr. Kaldjian.
It's my pleasure, Jennifer. It's a real privilege to be able to participate in your program.
In your perspective that addresses the ethics of physician influence and shared decision-making, you mentioned that in clinical practice and education, there's a lot of talk these days about the need for shared decision-making between patients and physicians. What do you believe is most important about this approach to medical practice, and how do you think physicians can make it happen?
Thank you, Jennifer. This is such a basic question. You know, when I talk to physicians about this topic, I sometimes ask, do you think shared decision-making happens? And sometimes I hear chuckling go through the group, because on the one hand, I think as physicians, we know that it does happen. But on the other hand, we also know that in many cases, it doesn't happen. And it doesn't happen sometimes because so much of what happens in medicine just sort of happens to our patients. And most of our patients are quite willing to go along with that, I think. And I think they also do so for good reasons, because thankfully, most of our patients trust us, I'd say probably most of the time. So that's all good. But at the same time, we realize that what this shared decision-making, even though it's a bit of a technical term almost these days, if you search PubMed and look at the literature, what it's really getting at is simply, are we having good conversations with our patients, right? And also I want to say that shared decision-making is really what informed consent is at its best. So what we're talking about here is, instead of informed consent as being, for instance, for those of you who are surgeons or proceduralists, you know, that form that needs to be signed, as you all have been taught when you were medical students, I trust, it's a process, right? And that process is the conversation. So it's a dialogue, it's a conversations, it's our explaining to our patients, and it's our listening to our patients in response to our explanations. And especially, I would say that it's about our willingness to want our patients to ask questions, because every question they ask reveals an area of uncertainty. And at the end of the day, we don't want them to be uncertain about things they don't have to be uncertain about. Obviously, medicine's full of uncertainties, but some of those uncertainties are unnecessarily part of the mix. So in working with our patients and having these conversations, the context is what is so important. And the context here is the patient's context, right? So if you're an orthopedic surgeon and you're thinking about replacing a patient's joint, you know what that's all about. You know what the evidence base for that is, what the studies show, et cetera, what your experience shows. But of course, what you need to know each time, and I know you surgeons and proceduralists out there, you know this, that your patients are the particular human beings they are, and they have particular ways to assess risks and benefits, to, you know, how much are they willing to suffer to get through to their goals, what probabilities are meaningful to them, and what are their goals of care. That's an extremely important aspect of shared decision-making in terms of what matters most to patients in particular. And we can't find that out unless we take the time to have that discussion with them. So another way to think also about shared decision-making is that it's predicated on shared understanding. So if our patients don't understand us yet, then it's hard for me to understand how we can actually have a genuinely meaningful something called shared decision-making. So I think that the bottom line to how does this happen is that it takes time. And I realize that these days, especially with all the electronic, you know, technology that we have and all sorts of resources to assist patients in gaining access to information and preparing for certain conversations, everything from brochures to online videos, et cetera, I realized that a lot of good stuff can happen there. But at the end of the day, medicine is an interpersonal engagement. At least I think it's supposed to be. And that's going to take a certain amount of time. And especially when your clinic days and your hospital days and your OR days are so congested, can we take that extra breath and give this patient right now in front of me the time that they need so that I can be reassured, they can be reassured that their questions have been answered, and that this is genuinely an understanding-based, shared decision-based way of going forward?
Listening to you, it sounds like so much of this is the patient, their family being heard, and just knowing that they, as you've said, have a say and that someone is listening.
That's right. No, it's that being heard and somebody's listening is so vital. But I think also what we have to remember is that I think obviously patients are different, their personalities are different. Some are very ready to let us know what their questions are. But others, if we don't create that space, and almost we could use the language of giving them permission, then I think that we might think that everything went well, but we might not actually realize that there were some gaps that could have been filled in if we had tried a bit harder to create that space.
The formal curriculum in medical education puts a lot of emphasis on patient autonomy. And we might sometimes hear people say that physicians should basically give information to their patients and follow their wishes without trying to influence the patients one way or another. What are your thoughts about that?
I believe it's mistaken and unrealistic. Physicians are always having an influence on their patients one way or another. How we speak, what we say, which options we include, how much time we give, all of this is going to be influential. But let me be clear here. I really believe autonomy is very important. So even though I have concerns about the way it's handled, I believe it's very important because every patient's individual freedom to agree or disagree with our advice as physicians, I believe, is simply a basic part of what it means to respect their dignity as human beings. And that's why the process of informed consent is so vitally important. And once again, as I said, it's not a form, it's an actual engagement to make sure that patients understand the information we need to provide and that they're genuinely consenting, that they're genuinely agreeing. That's what that consent means. It's their agreement. And if we move away from a genuine, robust, deep, profound understanding of informed consent, we are sliding into some terrain that I, quite frankly, am ready to say is ethically dangerous, because now it becomes basically a form of controlling our patients rather than respecting their freedom, which is so connected to their dignity. But let's also remember in all this that when we talk about shared decision-making, it means that there needs to be some genuine sharing from both sides of the doctor-patient relationship. And on this note, it's interesting to look at different models of shared decision-making. And if you ever have time or interest, there's quite a bit out there that one can read. And some of it might strike some of you as a bit too technical, a bit too almost sort of sophisticated, shall we say. But at the same time, I have found it very edifying to review some of this literature over the years. And what I have found particularly interesting, and I would say concerning, is that some of these models don't even include the need for a physician to make a recommendation to a patient. I find that really strange, actually. And I really believe that in the vast majority of situations, physicians ought to be able to give advice to patients based on the physician's expertise and experience that is then placed in the context of the patient's beliefs and values, priorities, goals, etc. This idea of sharing in decision-making then also brings to mind a very interesting idea that I suspect a lot of you listening to this might not have come across. And on one hand, it's a sort of philosophically technical idea, but on the other hand, hopefully I think it'll just simply resonate with your intuitions and you'd say, of course, that's the way life is. Okay, so what am I getting at here? And that is to say that there are some writers who refer to what they call relational autonomy, which gets us to think about autonomy in the context of our important relationships in life, rather than as a hyper-individualized and isolating focus on a rather superficial concept of so-called self-determination. When we think of autonomy in these relational terms, we see that autonomy is socially situated, interpersonally situated. This allows us to see that a patient may actually need assistance from people they trust to try to shift their perspective, which actually promotes their autonomy by allowing them to reevaluate and revise their perspectives and their reasons for acting. And I think all of us have experienced this in our own lives. Think about the last time you were mulling over or struggling over an important decision, and you wanted to actually check in with other people and get their perspective, use them as a sounding board, or actually ask them for their advice. And what you didn't want them to do is simply to say, well, whatever you choose is your choice, and that's it. No, you actually want someone to engage, but you want them to engage in a way that connects to what matters most to you, not just what matters to them, even though you might also be very interested in them. So this way of talking about autonomy helps us understand how physicians then fit into this relational idea. It helps us see why it's appropriate for physicians to actually exert different degrees of influence on their patients in different situations, depending upon what is needed at that moment. And this explains why, as I go into considerable detail in the upcoming article that this conversation is related to, this explains why we can very legitimately at times inform our patients or take a next step up into a more stronger realm or recommend something to our patients, or even stronger, to sometimes also attempt to persuade our patients when they don't at first accept our recommendations. And I realize that some of you, even when you hear the word persuade, you might be thinking, oh, that doesn't sound like respecting autonomy. Isn't that sort of against the rules here? Well, I suspect any of you who are experienced physicians, I don't need to tell you this because you've already done this. Because in certain circumstances, you've informed, you've made a recommendation to your patient, and now you're concerned that they are not agreeing with your recommendation. And so what do? Well, you start repeating yourself. You start thinking, well, I must give more information. You basically keep trying. What those are attempts at persuasion. So by informing, recommending, or sometimes respectfully attempting to persuade, these are different degrees of influence that, in ethics terms, if you think about the history of ethics, they reflect the emphasis on beneficence and non-maleficence, to use the two of the terms of the so-called four principles of bioethics. And beneficence, of course, just means do good. And of course, that needs to be unpacked, and different people can define and describe that in different ways. And non-maleficence, do no harm. Like the saying goes, first do no harm in the Hippocratic tradition. And this idea of using our notions of what's good for a patient and what's harmful to a patient, these are ethically grounded approaches to your expertise as a professional that actually respect your patients as persons by addressing their best interests. Whenever you think about best interests, you're really talking about what's good for the patient and what's harmful for the patient, wanting to promote the good and avoid the harm. And of course, that's from your perspective. And we know that sometimes is a perspective that the patient doesn't share. And that's the way life is, right? We have different perspectives on that. But the point is that you're allowed, in fact, you need to have that perspective as a doctor, because that's why you went to medical school. You went to medical school to understand what human health is and what's good for your patients. Not to say that you get to, at the end of the day, impose that on your patients. They have to buy into that concept, but you're allowed, and you're actually required as a professional to allow that understanding to pervade the whole process of shared decision-making. So while we can inform, recommend, and sometimes attempt to persuade, we have to always remember that the patient gets the final say about what is in their best interest. And that's why we should never manipulate or coerce our patients, right? There's a line, a very clear line I try to draw between respectfully attempting to persuade and then not sliding into manipulation or coercion. So when we make recommendations and at times do this process of even attempting to persuade our patients, we should admit that we are in fact trying to influence the patient's decision. But we're doing it in a way, I hope, that is still trying to respect their freedom to be the decision maker at the end of the day. So that trying to influence our patients is not only okay, I actually believe it's good, so long as we continue, as I said, to respect the patient's freedom at the end of the day to make their own decision.
You have spoken so eloquently about persuasion and respecting patients. And you say in the article, you touch on this, and then you, as you just mentioned, about avoiding into slipping into manipulation or coercion. How can you, as a physician, avoid slipping into that manipulation and coercion? Would you like to expand on that just a little bit? I know you touched on that just a moment ago, but are there additional thoughts?
Yeah, and one word to introduce at this point in the conversation is this word paternalism, or some might want to say maternalism, or others parentalism, whatever you want to call it. I think you know what it is. And if somebody were to ask you, well, what's wrong with paternalism? One way to get at this is to first ask, what's right with paternalism? What's right with paternalism is in other contexts, like a parent and a child, a father and a son, or a mother and a daughter, et cetera, et cetera. And that is to say that we congratulate people for being paternalists when they're supposed to be paternalists, right? When it's a parent of a 5-year-old child. That's the point, because a parent knows what's good for their child, or ought to know. And they don't defer to their 5-year-old child to make up their own mind about what they think is best for them. So that's the good thing about paternalism. Of course, some of you are thinking, how dare I speak about such things in the context of medicine? But I dare only by contrast, right? So I'm making a distinction here by raising that contrast, so that in medicine, of course, we are not our patients' parents. So we don't get to be and should never presume or slip into behaving as if were their parents. So what is wrong with paternalism is not the good intention that well-motivated doctors have for patients they really care about. It's rather the idea that you get to take to yourself something that is not yours to take. And that something is that freedom of the patient to be able to make their own decision. So even though we can be, and I think I certainly have experienced that as a physician at times, feeling it in the depth of my bones that I know what I believe is best for my patient, and they're saying no. And as it were, my jaw drops, I can't believe it. But that doesn't entitle me to take a hold of their freedom and control it myself. Painful as that is, right? That's the distinction. So that's the badness of paternalism, is taking what's not yours. But the goodness of it is that it's well motivated. But a lot of people have good motivations that can do some really bad things. So that's why we keep these things separate. We have to be clear about that. So how do we do this in the context of avoiding paternalism? So the first things that I would say is that there needs to be a respectfulness and a kindness as we communicate. Some of us, I have actually in more recent years spent quite a bit of time in the domain of what's referred to as virtue ethics. Those of you who are more familiar with ethics, actually probably all got a good dose of this, whether you enjoyed it or not in medical school, but the so-called principle-based approach to ethics: beneficence, non-maleficence, respect for patient autonomy, and justice. And some people think if they can even remember those 4 terms, somehow they've arrived and they can do ethics. I always tell my students here at the University of Iowa that just because you can, pronounce 4 words and spell them properly and remember them when somebody, quizzes you on them, doesn't mean you understand ethics or even know how to do ethics, right? Because each of those concepts is profoundly full of potentially different interpretations, and 4 principles, you have to define them, you have to balance them, you have to prioritize them. It's just the beginning of a conversation. So the 4 principles are, they are words that tag really important domains, no question about that. But that's sort of just a beginning. But these principles are these sort of rules for living, as opposed to virtues that are these moral character traits. They're who we are, that then predict how we're going to respond. So we all know that it's not just what one says, but even how one says it and how one goes about this really subtle, nuanced interpersonal exchange called shared decision making. So if we are not already the kind of people who others would describe and we ourselves would see as hopefully as being respectful and kind, it's going to be hard, I think, at times to avoid sliding into things like paternalistic attitudes, right? So we need to have these internal motivations and drivers that allow us to be the kind of professionals that hopefully we're all still aspiring to be. And some of us, even if we've been practicing for 10, 20, 30 years, we're still growing in this regard, right? There's this, in a sense, the sky's the limit in terms of how respectful and kind we can actually be. We also need to communicate to patients that we are for them. We're on their side, right? It's so important, and this is about trust, right? That if patients don't believe we're on their side, all bets are off. And if we ever presume to try to attempt to persuade them and they're not believing we're on their side, you may as well not continue down that road, right? There has to be that shared trustworthiness that is the glue of that relationship. We need to make it very clear that when we're making recommendations and sometimes even trying to persuade our patients who are at least initially resistant or hesitant, we're doing this for their benefit, not for ours. We're doing it because we think it is in their best interests. We're not doing it to make our lives easier or to make our practices more efficient or to make our quality metrics look better or to generate more income. If our patients don't believe that we're on their side doing it for them, as I said, I think all bets are off. And I would then also add to what I just mentioned, this idea of setting guardrails. So the first is we can explain our motivations to our patients. And I think at times we shouldn't take too much for granted. Obviously, if you have a long-standing relationship with your patient and they're already relying upon you for so much, you're probably not going to have to attempt to persuade them because they already trust you. They really want to follow, at least most of the time, your recommendations. But I think especially for people who are hospitalists, ER doctors, those who have never met a patient before, and within 5 minutes, they're having to go from a recommendation to an attempt at persuasion, it's important to explain our motivations, to make sure people know if we can sincerely say it, that we're on their side, we're doing this for them, it's not about us. And we also know that patients come to us with all sorts of preconceived notions based on their prior encounters with other doctors and even their prior awareness of the history of how patients, especially certain kinds of patients, have been treated. Some of you know these histories very well. So we need to try to do whatever we can to make it easier for our patients to trust us. Part of that is based on explaining our motivation. Even if you think it ought to be obvious and they should take it for granted, we shouldn't take too much for granted. So the second would be is to give clear and good reasons that relate to the patient's goals and values. This is to, in a sense, to put your cards on the table. Don't just assume that somehow the patients are intuiting from you what you take for granted as sort of obvious, but to actually put those reasons clearly in the conversation, making it clear that this is your interpretation of what's best for them and why, and then they can either endorse that, modify that, or reject that, right? Reasoning is a really beautiful thing in life. It's what so often frustrates us is that when we're told to do things or that we ought to do things, but we're not given reasons. We want to be able to understand the rationale so we can endorse it or not, and then decide what to do next. A third possibility, especially for more serious decisions, is to do the good thing of offering a second opinion. I think that actually, the possibility of that, I think that shows a humility on our part, which is to say that we're not trying to hide anything. We're not trying to control the conversational space or the decision-making space. We are so confident in the goodness of what we're recommending. We're happy to let somebody else in on that conversation too. And if we need to be better informed ourselves, we're not afraid of that. The third point about these 4 guardrails here would be to acknowledge that your patient has the freedom to refuse. I've actually said that to some of my patients from time to time, where even though it sounds and it feels a bit awkward to say it, but to actually say to my patient, pretend his name is Mr. Jones, I just want to say that I know that you know that I know that this is your decision at the end of the day. And I'm not presuming or pretending otherwise. So regardless of how long this conversation goes on for, I know that at the end of it, it's your call, and I'm going to accept that. I think putting that on the table can be a sort of a release valve for some patients, because they might be feeling that they're getting steamrolled into a decision that is actually starting to be very fearful to them and frightening to them. So that's what I would say about how we avoid this sliding into manipulation or coercion and avoiding paternalism.
You've just spoken about these guardrails that should hopefully assist in the avoidance of coercion and manipulation. But if a physician is really concerned that a patient is making bad or harmful decisions, and if those attempts to persuade the patient to reconsider are unsuccessful, what happens next? Can there still even be a doctor-patient relationship going forward?
You know, Jennifer, these are really tough situations for all of us. Hopefully, people listening will be able to say that it hasn't happened very often, but most of us remember very clearly the times when it has. And sometimes there just is this inability for minds to meet on a decision. And, you know, I think one of the more common arenas in which one sees this in the medical literature, and I make reference to this specifically in this upcoming article, is the so-called AMA discharges, or against medical advice discharges, where patients want to leave the hospital when doctors believe it would be dangerous for them to do so. So not just mildly unwise or not beneficial, but actually quite harmful. And I'm sure most of the doctors listening to this, if not all of them, in fact, all of them, because we're all trained in hospitals, we've all seen this, we understand what this is about. So there's a sense in which I like to sometimes use the contrary phrase, unshared decisions. So an unshared decision is unfortunately and sadly sometimes necessary. Again, quite rare, hopefully very rare in the experiences of people listening to this program, but we've all experienced them to some degree. But I want to suggest here that there's a certain moral goodness in agreeing to disagree. Not because we're really happy with it. In fact, it can leave us feeling quite unhappy, as if this is not the way the world is supposed to be. And yet we also know, certainly physicians know from experience, that this is part of reality, and part of being a mature professional is at a certain level to accept them. But the goodness of it, as opposed to just accepting it, I actually think it's helpful to be even more positive about something that doesn't feel positive at all. And the positivity of that is that it's reflecting a mutual respect for freedom and for the conscience of the patient, and also for your conscience as a professional, right? So it's actually a way, in a strange, tense sort of way, that integrity is manifested by allowing each individual human being to maintain their integrity by doing what they think is best for them. Okay. And as we experience these occasional unshared decisions, or what we think is about to be fully manifested as them, we need this virtue. Speaking of virtues, as I already mentioned, this virtue of compassion, right? So what is compassion? And I could say more about this if it were a different sort of occasion, but there's a deep connection, of course, between compassion and suffering. And I think if we understand our patients as suffering in one way or another, and I know that's a whole other conversation, but we need to have compassion on our patients. And I would even say sometimes with our patients who are making it more difficult for us because they might be raising their voices, they might be using foul language, who knows what it might be, or they might be perceiving us in certain ways, and it just sort of spirals down into a bad situation. But the point is if we have compassion, and we realize that our patients are suffering in one way or another, and then, speaking of another virtue, have the patience to seek to listen and understand, and then do our best to explain, to encourage to the best we can, and also try to persuade, but then to decide when to stop trying, right? Because too many attempts to persuade can really cross the line into disrespect, which the patient can easily experience as harassment, actually. And it may, in fact, be a form of coercion. So knowing when to stop is actually a part of practical wisdom in medicine. It's really important. So the goal in these challenging conversations, remember though, is still actually, it's not to get our way. It's not to say, oh, great, I got the patient to do what I believe is right. It's actually to try to promote the patient's autonomy, their best and best reasoned decision-making for them. And it's to promote what hopefully they believe, but certainly we believe is in their best interests. And we're doing this, we're prolonging this process of conversation and shared decision-making in a way that gives patients more opportunity to think and to deliberate with someone, you, who genuinely and respectfully cares about them and their health. Now, another point that comes up here, though, is when I mention health, we think, well, of course, health, it's healthcare. We see it on billboards, go to medical school, and we become experts in health. But actually, there are different models of health, and I won't, of course, in this context, go into this kind of detail. But we need a concept of health that is holistic, it's integrated, one that does not look narrowly at only the so-called biomedical concerns, but also the broad range of issues encompassed by what we can refer to as the so-called biopsychosocial spiritual model of health. Yeah, there's a lot in there to unpack, but that's life, isn't it? And all of us who have cared for patients, we know that all of these things are integrated and involved. And if we're not aware of that, we shouldn't be surprised sometimes that if we're just focused on a broken hip or just focused on, angina and the possibility of a lethal MI, but fail to take in the broader realities that the patient is experiencing, we're not going to make headway with our patients, right? And it's not to say that we can be experts in each of these four dimensions, the biopsychosocial, spiritual, but we need to be sensitive and aware of the fact that these things are in play. And sometimes the course of wisdom, of course, is to get other people involved who have expertise or relationships with the patient in those dimensions, right? So there are ways we go about that. And such a model, this biopsychosocial spiritual model of health, can only be used if we take the time to get to know our patients as persons, not just as decision makers or just as choosers, right? But actually as persons, so that we're taking seriously their freedom to make choices. But we also want to know in some deeper ways, what are their beliefs and values that are driving their choices and their preferences? Again, that takes time. So another theme here in terms of what we're trying to do, even at these moments where we're realizing, I think we're going to have to agree to disagree. I like this word fidelity or faithfulness, so related to trust, the trustworthiness of the doctor-patient relationship. Are we willing to hang in there with our patients when our patients do not do what we think is good for them? And in fact, might be doing something we think is really, really bad for them. But we need to be as accommodating to their needs and preferences as we can. But I add here an important caveat, and that is, so long as it does not compromise your integrity or conscience as a human being and as a professional. That's another really important discussion. But this is to say that obviously what we're talking about here in this aspect of shared decision-making is the freedom for a patient to go his or her own way, and our not interfering with their freedom to do that, right? There's a different dynamic when the patient is requesting, urging, or even demanding that we do something for them that we don't think is good for their health. Right? So a surgeon who concludes surgery is not indicated, they don't say yes to the surgery, no matter how much the patient wants it, if they believe it's not good on balance for the patient's health, right? So that's that mutual respect for integrity or conscience, which is so important. But this fidelity then, as I'm about to wrap up my comments on this question here, when we think about this, what does it look like? So say if you're an emergency room doctor and a patient leaves the hospital against your advice and then comes back 24 hours and you're on shift again. So what's your attitude toward that? Is it this profound frustration, which of course we all know is understandable? There's the sense of maybe a sense of futility or a waste of resources, et cetera. I'm not naive about that. But I'm also not naive about the fact that we are trained, I hope and trust, as professionals, to have these deeper sensibilities that say, in our weakness as human beings, ourselves and our patients, we have to be willing to work in environments that are messy, that are imperfect, where patients are certainly at times not at their best, especially when they're in pain and really sick and not doing well. But to receive patients back when they're ready, I think is a really important part of what we're supposed to be doing. And I certainly have heard many good stories of where, of course, this happens. And I obviously realize that you have medical legal responsibilities in this regard. But I'm also talking about, again, this idea of the virtue side of it that says, are we really on our patient's side, and can we accommodate them in their needs as much as possible? I think also in primary care, for instance, so I'm a general internist, and in my earlier days did hospital-based work, but then also a lot of outpatient work. And how are we willing or not to hang in there with our patients over the years, actually, when on certain very basic areas of health and wellness, our patients are unwilling or unable to turn the corner and to do what we believe is best for them, either in terms of, lifestyle habits, or also in terms of willingness to take medications that we think would be really good for them, et cetera. There's a real need to be able to work with our patients, to hang in there with our patients. And I would also say to do so without resentment, right? And I would say that we want to do that in the same way we would want to be treated by someone else who disagrees with us, right? So that not just a mutual respect, but actually a kindness and an acceptance of our shared weakness and struggles as human beings, and in that way to really be willing to give of ourselves for the good of our patients, and to be willing to be patient and compassionate, and to remain faithful in the doctor-patient relationship to the best of our ability.
This has been such an informative and enlightening conversation. And before we conclude, are there any final thoughts or key pearls you would like to share with our listeners?
Thank you, Jennifer. It's been a real pleasure to be able to participate in this. And when I talk to medical students and others here about these 5 sort of points on a spectrum, from inform to recommend to persuade, but to not manipulate and not coerce, I actually suggest that in real time, when we're having what we think are more difficult conversations with patients because we're not seeing eye to eye, I think it can be helpful to be mindful of where you are on that spectrum, to be sort of deliberate about that, both to help avoid sliding into the domains we shouldn't go into, but then also if we think now, I think I've just put the gear into attempt to persuade, like you're driving a gear shift car, right? And then to tag that in my own mind, and then possibly tag that for the patient, so that there's more openness and straightforwardness and less surprise or less reason to wonder, what's the doctor doing here? Why do they keep insisting? I thought I just told them no. Why won't they hear me? Just to be able to put that on the table and then use those guardrails, make ourselves clear, and hopefully, even if at the end of the day there is that unshared decision, the hope would be that we have gone about the process in such a way that our patients actually appreciate us more rather than less, because they believe we have respected them and treated them kindly.
Thank you again for your time today. We really appreciate your being with us.
My pleasure.
We hope you enjoyed The Practice of Medicine. For more episodes in this series or SMA's The Business of Medicine podcast, go to sma.org/podcasts or subscribe to us on iTunes, Google, Spotify, or wherever you get your podcasts. For more information about SMA's physicians and training, please visit sma.org/PIT. And thank you for joining us.